Okay, show start. Live is recording. 3, 2, 1, start. Hello, good afternoon. Thanks for joining us. Today, this afternoon, the talk show organized by health talk show organized by Lam Wah Yee Hospital. My name is Dr. Yew, and I'm going to be talking about bleeding in the eye. It sounds morbid, but it's a quite common condition seen in my practice. I'm the cataract and vitreoretinal surgeon here in Lam Wah Yee. So welcome to the show. So when we talk about bleeding in the eye, we need to know where exactly is the bleed. Many a times, you'll be thinking of the eyes being red, or somebody with trauma. So the easiest way is to classify the bleed according to its location. The picture here shows subconjunctival hemorrhage. The first one, this is quite common. When you wake up in the morning, suddenly you see the eyes being red. No pain, vision is good. Usually it's quite benign. Can be because you rubbed it or there's a cough or something, and it usually goes away within a week or two. No treatment needed most of the time, unless the bleed, of course, gets worse, and then we have to find out what's the cause. The picture here shows periorbital hemorrhage. Usually follows a trauma, a head trauma. You had an injury somewhere on top, and then the blood starts trickling down around the eye. So, but today's talk is not about any of this, because these are the bleed outside the eye. The focus on today is about bleeding in the eye. So we call that intraocular bleed. It has different names to denote the location of the bleed. So the first one is hyphema. Hyphema means blood accumulating on the front part of the eye. This is called the anterior chamber. So if you have blood accumulated in this space, it's called hyphema. If you have blood accumulated in the back part behind the lens, in the vitreous body, and that's called vitreous hemorrhage. If you have blood accumulated under the retina, this yellow layer is the retina. Retina is the nervous tissue. It's like the film of the eye, capturing the light. And you have bleeding under the retina, we call it subretinal or submacular hemorrhage. Hemorrhage means bleeding. And if you have bleed in the choroidal layer, the chora is the layer behind the retina, and that we call it choroidal hemorrhage. They all have different reason, different causes, and different presentation, as well as different treatment. But whichever hemorrhage, these bleeding will blur the vision. It will affect your vision. So how do you know you're bleeding? The easiest one would be vision being blurred. Suddenly, that's the usual cause. Out of the blue, suddenly vision not quite seeing, either because of floaters or because of distortion. Say you see the lines getting bent, so that's distortion. If you have floaters, it could be just shadows moving around in the field of view. If the bleed is massive, then the whole thing would just blur out, dim, vision being dimmed. Or you might even see a reddish hue in the field of view. Black patches in the central and peripheral vision, and that's related to macular bleed. If the bleeding is massive, so much so that the drainage of the eye is blocked, and then the pressure of the eye goes up, causing high eye pressure, and then you might even feel a fullness around the eye and also eye pain. So these are the symptoms that can suggest one has bleeding in the eye. If you have this, you should get treatment as soon as possible. So we'll be talking about a few common causes of bleeding in the eye. Number one, most commonly, is related to diabetes. So diabetic retinopathy forms the majority of patients presenting in my clinic with bleeding inside the eye. The other common condition is retinal vein occlusion. This is like a stroke. Blood vessels block, and then you get bleeding in the eye as well. The third one is wet AMD. You have the dry and then you have the wet type. The wet type is indicated by presence of fluid or bleeding under the retina. The other big groups of disease that presented with bleeding in the eye is retinal tear, as well as presence of that could lead to retinal detachment. Somebody with trauma, obviously, or somebody post-surgery, for example, glaucoma drainage surgery, eye being soft, you can also get bleeding in the eye as well. But they have different sort of presentation. So diabetic retinopathy. Globally, there are about 463 million people who suffer from diabetes. It is a very, very huge burden on our medical facility right here. In Malaysia alone, the National Morbidity Health Survey #1, done in 1986, showed about 6.3% of our people suffers from diabetes. 1996, 10 years down the road, the prevalence has gone up to 8.3%. Another 10 more years, 11.6%. And not too distant in the past, it's gone up to 15.2%. And the latest, most recent one is about 18.3% of the adult population for somebody above 18 years old. That means in about 1 in 5 people, 1 in 5 adults suffers from diabetes in Malaysia, according to the 2019 registry. And that's a lot. So out of this 18.3, out of these 3.9 million people with diabetes, about 10% of them do have some sort of eye problem, do have retinopathy. And so that doesn't mean if you have diabetes, automatically you have eye disease. About 10%, so 1 in 10. But if you don't get checked early, you might miss them. So this is a picture of a normal retina. You can see the optic nerve, the blood vessels. That is the center of the macula. This is the fovea. So this is a healthy retina picture. This is a picture showing early stages of diabetic retinopathy, where you have microvascular leakage. What happened with diabetes is that after some time, it usually takes around 5 to 10 years, where blood sugars has damaged the small capillaries in the eye. That leads to blood vessels being blocked, or blood vessels started to leak. Once you start blockage, you get aneurysmal changes, meaning that you get blood vessels getting small little bulging out of the blood vessels, and sooner or later these little bulges would rupture. And when they rupture, you get tiny little bleeding spots in the retina. So these are early stages. We call these dot and blot hemorrhages. And the yellow ones are proteins leaked out from the blood vessels. Normally at this stage we don't need to do anything to the eye, but definitely the diabetic control has to be good, otherwise it will get worse. As the disease progresses, and then we might reach the stage of proliferative diabetic retinopathy. This means blood vessels have started to grow, and it's not just a little bit of bleeding, but you get huge florid blood vessels growing. Why it happens? Then that's because the retina is not getting enough oxygen. Not getting enough oxygen causes the retina to secrete a vascular endothelial growth hormone, a special kind of chemical reaction that causes blood vessels to grow in order to increase the supply of oxygen to the retina. We have an increased demand, but you don't have enough supply to support it. So this is how the eye responds. But it is not good, because once these blood vessels grow, they break very easily, and then sooner or later you get bleeding, massive bleeding coming out of them. So when we see all these abnormal blood vessels growing left and right, as well as if you start to see bleeding in the eye, and that is the stage where the eye will suddenly take a bad turn very quickly if no further treatment is done. So what is the treatment then? Well, before we get to treatment, the other complications from diabetic retinopathy is to get Rubeosis, Iridis. This is a condition where the blood vessel starts to grow on the front part of the eye. You can see blood vessels growing on the iris. The iris is the brown color part forming the pupil. This will lead to glaucoma, where the eye pressure would shoot up, and then the nerve would suffer even more damage. Once these blood vessels bleed, you can get massive bleeding in the front part of the eye, and that's what we call as hyphema. These are not good signs. When the eye has reached this stage, treatment is always very difficult, and the prognosis is not good. So what's the most important treatment? Laser. pan-retinal photocoagulation therapy. What it does is that we use laser to burn away the retina. We sacrifice the peripheral retina. We want to salvage the central part, because about 80% of our vision depends on the central retina, so that we have to protect it. We're not too worried what happened to the side. Of course, after laser, then because the retina is burned, we kill them off. So night vision suffers. You can't see very well in the dark. You have to switch on the light, and peripheral vision will suffer quite a bit as well. So, but you have no choice, because this is the most effective treatment in preserving vision, to save the eye from getting blindness. By doing laser, we reduce the oxygen demand, and also that will lead to reduction of the vascular endothelial growth factors, the VEGF. The VEGF is the reason why blood vessels grow. So after laser, that chemical mediator will reduce, and the blood vessels will shrink, and bleeding will stop. This is how a laser session looks like. It's an office-based procedure. You just sit on a slit lamp, mount a laser, and then the laser will cause whitish burns on the retina. It takes approximately 10 to 20 minutes per sessions, and we normally do it in around 2 to 3 sessions instead of doing all in one go. Depends on the severity. If the bleeding is bad, we might want to do more laser on the first round. So this is how the laser therapy looks like in the eye. The same eye, after laser treatment, you get blanching of the retina on the periphery. We don't laser the center, because if you laser the center, then the patient can't see, so we laser the side. Give it ample time, these blood vessels will shrink and the bleeding will disappear after a while. This patient is lucky because the bleed wasn't massive enough. We were able to laser it. If the bleeding is worse, fills up the whole cavity of the vitreous, cavity, then we can't do laser, because laser can't get through the blood. A new treatment modality is by doing injection. The Protocol S study from the US recently shows a series of intravitreal anti-VEGF injections. Anti-VEGF stands for it's an antibody designed specifically to take away the chemical mediator causing blood vessels to grow. Using this treatment modality can also achieve similar result, minus the burn on the retina. However, because the injection lasts for about a month or so, repeat treatment is necessary in order to maintain effectiveness. So it's a new way of doing things. It's very powerful in resolving the bleeding in the eye. However, it's not suitable for everybody. So treatment is like this: an injection of 0.05 mils of liquid into the center of the eye. It's done approximately 1 to 2 months, repeated every 1 to 2 months. That is becoming an alternative to the true and tested treatment with laser. When this new treatment was introduced, it was mainly to treat diabetic macular edema. Diabetic macular edema is not bleeding, it's just the nerve in the center of the eye was swollen in people with diabetes. In the past, treatment was laser, but it wasn't good, and then this anti-VEGF therapy was found to be superior. So it was used as the treatment of choice for treating macular edema. But we found that apart from edema, it also helps with the bleeding. So this is the part where the nerve is swollen in diabetic macular edema. Treatment is by doing those sort of injection. So what happened if the bleeding got worse? As you can see in this picture, the bleed has spread all over the place. And if you can't see the retina, the laser can't get through. Obviously, you can't do the treatment. One way is by doing injection. Yes, perhaps. Injections can help to buy some time, shrink the vessels. But if the bleed is too massive, you don't have much options, but we need to clear it off in order to help the patient to achieve vision in a faster time frame. So surgery is indicated when the bleed is massive. The surgery is done by keyhole microsurgery, where we make 3 little holes, we put the tubes in, and one is a guillotine cutter that sucked and cut out the vitreous gel together with its blood. one port is for infusion, where water is kept infused. This is the part where the water goes into the eye and helps to maintain the eye pressure. The other two ports for us to put our instrumentation in. Once the blood is cleared, we will do the laser from the inside. This is called endo laser. At the end of surgery, all the laser is done and treatment is completed. So the treatment, the surgery itself depends on the finding. If it's just the blood, there's no further problem with the retina, for example, no other scarring or no detachment. The surgery is quite straightforward. Once the blood is cleared, do the laser, and that's it, end of the operation. However, sometimes surgery is not as straightforward because of existing new scarring on the retina or detachment. Then silicone oil may need to be might be indicated to fix all this detached area of the retina. This is an example of a picture of the patient where the surgery was done, oil was inserted. As you can see, the gleaming surface of the retina because of the oil. But definitely after the operation, the view of the retina is a lot better. The patient's vision has improved from hand movement all the way down to 636 because of the oil. I usually keep the oil in the eye for a couple of months to make sure the retina is all secured and stable. Once the oil is removed, then they should get back the pre-morbid vision. Means the patient should be able to get back the original vision of what it was before the bleed. So that was diabetic retinopathy, which by far is the most common cause of bleed that I encounter in my practice. The other condition that I wish to highlight here is retinal vein occlusion. This is a fancy name for another word called stroke in the eye. Basically, the blood vessels blocked, and because of the blockage, you get bleeding inside the eye. It happens suddenly. The complaint would be something like sudden loss of vision. You can't see on waking up, or suddenly you can't see, or whatever it is you're doing. Vision gets dim. How bad the vision's affected depends on the area involved. For example, this is central retinal vein occlusion, one of the main blood vessels blocked. You get bleeding all over 4 quadrants of the eye. As for the picture on the left, this is just one little branch here that's involved, so you get bleeding on one area of the retina. Now in the past, there's no treatment as well. This is essentially a stroke in the eye. So what can we do? If we found there are new vessels growing, now why blood vessels grow in this case? It's just like diabetes. The retina doesn't get enough oxygen. They suffocate. So when it suffocates, it causes VEGF to be produced, and that causes blood vessels to grow. Again, if you see all these features, treatment is by doing laser, just like in the diabetic eye disease. If we see rubeosis and if we see blood vessels growth. However, if there's no complications, then it's just observe. We don't do much. If we found that the nerve is swollen, in the case of vein occlusion, again, treatment is by doing the injection, the anti-VEGF injection, or in this case, intravitreal injection of steroid might be another option. So this is a steroid implant. This is a steroid implant. That's the injector. We inject, it is as small as a grain of rice, and with it inside the eye, it will slowly ooze out the medication, and that helps to reduce the swelling. Once the swelling is reduced, patient's vision will improve following treatment. Of course, the vision, how much vision recovery depends on the severity of the vein occlusion. So if it's bad, perhaps the treatment might not help at all. But if vision blurs because of the swelling of the nerve, and by reducing the swelling, we were usually able to salvage, perhaps recover more than 50% of vision for the patient. So that's the other treatment. Apart from steroid, it will be the same as anti-VEGF, the one I mentioned just now. So the third disease I wish to highlight would be ARMD, age-related macular degeneration, and of course the wet type, because the dry type don't cause any bleeding, only the wet type. Now, what is ARMD? ARMD is a degeneration of the central retina due to age, obviously. Essentially, there's no treatment for it because it's a degenerative process. But for some patients, it might reach a stage where suddenly the layers under the retinas, it breaks apart, and that leads to bleeding. Sudden leakage of water and blood into the subretinal space due to degeneration. And that leads to sudden worsening of vision, and distortion, blurriness, or even a non-seeing area in the middle. Risk factor are somebody who's above 50, of course family history, somebody with smoking, blood pressure, as well as obesity. This is a picture here. This is a picture here that shows presence of subretinal bleed in the middle of the eye, in the middle of the macula. This is an OCT scan showing cross-section of the retina. We are focusing on this little black space between the retina and the RPE layer that usually denotes the presence of fluid leakage or bleeding. When we see blood in the presence of drusen, this is invariably a case of wet ARMD. As you can see from a diagram here, it shows the blood vessels from underneath. You get blood vessels from the choroid growing into the Bruch membrane. And that leads to bleeding under the retina. So in the past, people tried laser, but because it's right in the middle of the eye, it's not a good treatment option because laser takes away the vision right in the center, because the center is the part that we want to protect. With the advent of symptoms of ARMD is central vision distortion and general loss of vision if the blood spills in the vitreous cavity. So that can also lead to, because of the bleeding, it can cause breakthrough bleed. The blood will spill into the vitreous cavity and cause massive bleed in the eye. So this is a picture that shows how a central vision distortion looks like, and also central scotoma. If you have a bleed in the middle of the eye, you can't see through the middle, you can see through the side. But if the bleed gets worse, and then the non-seeing area will extend. So treatment nowadays is by doing anti-VEGF therapy. We do injection. These anti-VEGF injections like ranibizumab and aflibercept are very effective in controlling the disease. It has revolutionized the treatment of ARMD and has saved many eyes because of that. If the bleed is massive, say out of the blue, you get somebody who can't see at all, and then because of the blood has gone into the vitreous cavity, again, we need surgery to clear out the blood before we can be sure what's going on. And if ARMD is the cause, after the surgery, a series of regular intravitreal anti-VEGF injection is the treatment of choice. This picture again shows how we do the anti-VEGF injection. And then that's the picture that shows how we do the operation. The other big group of cause, the other big group that I want to discuss regarding cause of vitreous hemorrhage is retinal tear and detachment. This is right. As you can see, this is a picture of the retina where it's detached from the top. This is the top part and that's the bottom part. You can see a hole there, a tear in the retina with the bridging blood vessels. You can see the blood vessels crossing the tear onto the other side. Right? Why this tear occurs? This tear happens because as we age, the vitreous gel would shrink. It will shrink, it will come forward to the middle, and then it will separate from the surface of the retina. If there are some areas of weakness on the retina, this movement of gel might tear the retina apart. So just like this, it has caused an avulsion in the retina, and then the blood vessels over it might just get torn, and you can get a massive bleed because of that. So for somebody who's non-diabetic and you get a huge amount of bleeding in the eye, that is the thing that we need to rule out, because if we detect it early, we can prevent a detachment like this from happening. So the area that's detached, as shown in this picture, that part of retina is no longer seeing. It will be like sort of an area of darkened vision. And if this retina is not treated, sooner or later, all the retina will get pulled apart, and then patient will lose their eye, will lose their vision. All right. Sorry, I need to highlight this other picture here as well. As you can see on the left, this picture here shows the gel coming forward. At the beginning stage, this is called vitreous detachment. It will happen to almost everybody at some point in our life. Normally it's around 40 to 50 years old. So once the vitreous gel detach, you get all these hardened areas of the gel surface, and when we see through the bright light, you'll be able to see floaters, and these are the floaters inside the eye, because these are previously, this is the surface of the gel that previously was attached to the retina, but now it's come forward, it's loosened, it's wobbling around inside there, and that causes floaters. So many a times when we say if you have sudden increase of floaters, that's likely because the gel has come off. But we can't be sure, because this gel movement can also lead to detachment. And if you have a tear in the retina, you will get bleeding. Bleeding also causes floaters. The only way for sure is if you have a sudden increase in floaters, you gotta see the doctor or see the optometrist, get the eye tested to make sure it's not blood and it's just the vitreous gel that's detached. Because if the floaters is due to this, then you're probably quite safe. If it's a blood, then we need to be sure it's not a torn retina. Yes. So how do we treat a torn retina? If there's no detachment, we do laser. We laser around the tear. I can't put a sticky tape or I can't put a stitch onto the tear, the torn retina, but I can do laser around it. Essentially, this is welding. If I weld it, after some time, this area will get adhered. The retina will get stuck onto its underlying bit, and this little tear will no longer cause any problem. This is a picture to show how the retina a torn retina was treated in the past. You see the torn area is still torn, obviously, but water will not be able to go through the tear and cause further detachment. This picture here shows how a bridging vessel looks like. You get a blood vessel growing across the tear, and obviously this little blood vessels is prone to break, and then if it breaks, you can get a massive bleed in the vitreous cavity. Now, even say if you have done the laser around this area, if there's no detachment, this little bridging vessel can still cause massive bleed. So it's not surprising for somebody to have a previous tear treated with laser, months or years down the road, suddenly get massive bleed, but you can't be sure if it's because of these bridging vessels or new tear. So if the bleeding is massive, the only logical treatment would be to do an operation to clean the blood and see where's the source of the bleed. Identify the source, treat the cause, and the eye will be safe. Don't leave it to chance. So how do we treat retinal detachment? If the retina is detached, this picture shows attached retina, right? If the retina is detached, you can't laser around it because you need the retina to be on its bed before the laser takes hold. So treatment is either by doing pneumoretinopexy. Pneumoretinopexy means putting gas in the eye, hoping the gas bubble will push the retina back, or we do sclerobuckling. But if there is concomitant bleeding apart from detachment, pneumo and sclerobuckling is not a good choice because you can't see through the blood. You don't know what we're treating. And the treatment of choice would be to do the surgery as I mentioned just now, the keyhole surgery called pars plana vitrectomy. After that, putting gas or oil to support the retina while waiting for the laser to make it seal. It takes about a week for the laser to work. After laser, you need something to hold on to the retina. If you can last for a week or two, the seal is complete, and then you can remove the tamponating agent, whether it's gas or oil. So this picture shows how the surgery is done for a detached retina. This is a torchlight, and that's the guillotine cutter. We cut out the gel. After that, we suck out the subretinal fluid. And by using air bubble, we push the retina back onto its original position. And after that, we do the laser around the tear, followed by a tamponating agent, either a gas bubble or silicone oil. Depends on the technical complexity. Coming to the last group of bleeding cause is ocular trauma. Now, of course, the trauma by itself is a huge topic, and I won't be able to cover all that in today's talk session. It's just to highlight that trauma obviously can cause bleeding in the eye, especially blunt trauma to the eye. You don't see any bleed on the outside, but you can get bleeding on the inside, either a hyphema, a vitreous hemorrhage, a choroidal hemorrhage, whichever. Any layer in the eye can be affected. That trauma can also lead to choroidal rupture. Choroidal, remember, choroid is the layer under the retina. It can just burst apart. Choroid is actually a highly vascularized area, a lot of blood vessels in there. If it ruptures, then you can get massive bleed there as well, causing subretinal bleed, subretinal hemorrhage. This is a picture that shows subretinal hemorrhage. An OCT scan. There's a break in the retina, choroidal rupture, and you get massive bleed underneath there. Once the blood resolves 6 months later, vision is improved to 630, but you get a scar around it. Now, obviously, if the blood has gone through the retina onto the vitreous cavity, you won't be able to see that clearly. Then you need surgery to clean up the blood. Alternatively, if the tear is bad, you might get multiple bleeding spots, multi-layer hemorrhage in the retina. You can get hemorrhage pre-retinal in front of the retina. You can get bleeding behind the retina, or even under the choroid. So this is not uncommon in the case of trauma. Once the blood dissolves and all the wounds heal, you can see scars under the retina. These are choroidal rupture, choroidal scarring. Any scars in the choroid potentially can lead to more bleeding because of neovascularization. So we have to keep monitoring these eyes to make sure that they do well. Choroidal. Okay, a bit of highlight. I'm going to touch a bit on choroidal hemorrhage. Now, suprachoroidal hemorrhage is one of the most feared complications in any eye surgery. It happens because the eye becomes too soft. When we cut the eye, the pressure in the eye fluctuates. In the past, when the machines are not as good, this sort of complication was fairly seen, but nowadays they're quite rare, thankfully. It happens because of bleed behind the choroid, suprachoroidal hemorrhage. It can occur because of trauma or because of tumor in the eye, for example, a choroidal hemangioma. Normally, the bleed is quite massive. If it's so bad, sometimes you can get kissing choroidal detachment. The outcome, the visual outcome is usually not as good once even the blood resolves. So ideally, we want to prevent all these things from happening. Right? For suprachoroidal hemorrhage, sometimes we might have to drain the blood clot, but we don't do it at the same time. You have to wait a couple of weeks for the blood to liquefy, and then you can do the surgery to drain it off. So the take-home message from this talk is, if you have any of these symptoms, blurred vision, vision becoming dim, if you have sudden onset of floaters, not old floaters, we're talking about new floaters, if you see flashing lights, lightning, if you see this vision distortion, or an area of non-seeing, a visual field, some part of it that you can't see, a black patch in the central vision, you need to get your eyes tested. Don't keep it don't sit on it, all right? Because early detection and early treatment is important. Early treatment saves your eye. You'll be able to maintain your vision. Late treatment is always difficult. Second take-home message is, if you've been told to have diabetes, you need to get your eye tested as soon as possible as well. Frequently, I still encounter patients who's known their diabetes for 10, 20 years without ever getting their eyes tested. By the time they come to me, it's already blood inside there. So that's not ideal. We always want early treatment. I think that concludes our talk for today. Any further questions? I'm happy to take them. Thanks for staying with me. on this lovely Wednesday afternoon. All right, we do have a few questions. What is the meaning of AMD? From Ade Okoro. Also, the next question was also with IB. Meaning of AMD. AMD stands for age-related macular degeneration. There are many diseases affecting the macula. And they all have different names. AMD is a specific disease, and we see that because it happens mostly in an elderly group of people. Right? Bleeding from eye drop use. As I've shown just now, most of the diseases, most of the intraocular bleed are treated, depends on the cause. If it's, for example, if it's a blunt trauma with some hyphema, some bleeding, if there are no surgical indication for treatment, yes, we do treat conservatively with eye drop. Most of the time, all this blood will disappear given enough time. But if say the bleed is massive and it's in a vitreous cavity, sometimes early surgery is better because we are able to resolve the problem as early as possible, treat the underlying cause, instead of sitting on it and make things worse. So it all depends on the cause. Normal is not cool. On normal, not is. On a normal, not is it cool to check up your optics without any symptom? Seems like, yeah. For the question was about if we should get our eye tested without if there are no symptoms, if there are no eye problems. My advice generally is if you are somebody who's about 40 and above, it's fair enough to get your eye tested once every few years because there are a lot of silent diseases that if you don't check, you don't know. For example, diabetic retinopathy is one of them. Especially if you have history of glaucoma, yes, you should get your eye tested. For the younger adult, normally it's fine. You should be all right unless you have some specific problem. Then you do welcome you all to drop by for us to have a look. It's hard to. The best advice can only be given after a thorough assessment of the eye. Mr. Liu was asking, what's the main cause of retinal detachment during daily habit? The main cause of retinal detachment, unfortunately, has nothing to do with what you're doing. It happens because of the vitreous gel getting detached. It happens because of aging. It can happen just by you moving your eye, looking left and right. Obviously, if you're involved in a trauma, if you're involved in an accident, or if you had a head knocked on something, yes, that can exacerbate retinal tear and detachment. But by far, majority of the cases happen just because of the vitreous gel pulling the retina, causing a tear. There are a specific group of people who are at higher risk of this happening. If you are short-sighted, for example, or you have some peculiar disease in the eye, like Stickler syndrome, then yes, these people are at much higher risk of getting retinal detachment. For the rest of us, it's about 1 in 10,000 the odds of you getting a retinal detachment. The risk is high if you have cataract surgery done, but then again, it's still an uncommon disease by and far. Next question from Stephanie. Are those with glasses from a young age, around 10 years old, at risk of getting retinal detachment? Yes, as I mentioned, Miss Stephanie was asking, are those who needed, for somebody who's 10 years old and who's been wearing glasses for a long time, what about their risk of getting retinal detachment? Depends on how high the short-sighted is. I presume you're talking somebody who's myopic, somebody who's short-sighted. Short-sighted eyes are long eyeball usually because when the eyeball is long, the retina is stretched. So therein lies the weakness in the retina, which is prone to prone to be torn by the vitreous gel. So it depends on how high the myopia is. Doesn't mean everybody who wears glasses will get retinal detachment. Right? If you're concerned, no harm getting your eye tested. That's probably the easiest the easiest answer. But generally it depends. If for somebody who is short-sighted around 3 or 4 diopter, I think the risk is negligible. But if you are 6 diopter and above, we consider that as high myope, and no harm get your eye tested just to know what sort of risk if you're at. Say we found during examination we found you have areas of lattices. If we found areas of peripheral retinal degeneration, then you should know that your risk is higher compared to others. However, really there's nothing much you can do. Just beware of the signs and symptoms of, for example, flashing light and floaters. If you need to, get your eyes tested. If there's tear, if you're found a retinal tear, laser is the way to go. Worst case scenario, if the retina is detached, then you need surgery. Whatever it is, if you have problem with the vision, you need to get tested as soon as possible. Is there other treatment apart from injections for AMD? Essentially, I need to make this clear, AMD has no treatment. All right, it is a degenerative process because of aging. The cells has stopped functioning well. It is unable to maintain the physiology. Is unable to support the retina any much longer because it's essentially a wear and tear problem. Now, so for the dry AMD, generally there's no treatment whatsoever, right? But if it reaches a stage where the cell starts to break apart and you get blood vessels growing in, blood vessels ruptured and bleeding, that particular patient's vision is gonna drop very quickly and very significantly over a very short period of time. This is where injection nowadays comes in to help to prevent that sudden drop in vision. It tries to maintain it as long as possible to prevent bleeding, taking away the vision of the said person. So we can sort of control wet AMD, but you really can't reverse it. There's no cure for it, unfortunately. All right, I think thanks a lot. No further questions. Happy that you're with me this afternoon. If you do have any other query, I'm happy for y'all to just drop my clinic, give me a ring or send me an email. Either way, I'm happy to answer any further questions from y'all. Thank you very much. So, oh, sorry, there's one last question. What was it? Also can take nutrient for nutrient. So there's another further question asking about. There's another question asking about nutrient. What sort of nutrition that we should take to protect our eye? That depends. That comes down to personal belief. There aren't any hard scientific facts to say one particular diet is better than the other when it comes to eye health protection. I would say eat healthily, right? There are, of course, certain vitamins that was found to have beneficial effect if one has, for example, AMD, or if one has diabetic retinopathy. But all these are just supplements. I wouldn't go into the details of supplements because I think ultimately they're just supplements. If you control if it's diabetic, ultimately the main treatment is still to control your sugar. If it's AMD, essentially there is no treatment for it. Avoid smoking, avoid the sun, avoid UV. Perhaps these two are pretty important risk factors. As for diet, there is no scientific evidence to back one diet over another for that, right? Those with low blood platelet around 50 at risk of bleed. Yes, if you have low blood platelet from whatever cause, you can get bleeding in the eye. You can get bleeding anywhere in the body. So that's a given. How about? Yeah, it's one more question. about PDT. Yeah, PDT stands for photodynamic therapy. PDT has been around for a long time, way longer, even before the advent of anti-VEGF injections. Um, in the past, before PDT, people were doing laser. Obviously, remember I was saying when you laser the retina, you can cause a burn. And obviously, we can't laser the center of the eye. This is where the macular degeneration is. Now, one way of going around it is by doing PDT. Before we have all this injection, it is by injecting vertiprophin, and then you use a cold laser, activating the vertiprophin as they go through the blood circulation under the retina. Yes, it's much gentler than the regular laser, but it can still cause damage to the vision. It still causes patient lose vision around the area of PDT. We have a lot of studies showing the superior effect of anti-VEGF compared to PDT. In some conditions, for example PCV, the jury is still out, meaning that many people still do a combination of PDT and anti-VEGF as opposed to anti-VEGF monotherapy, but that's beyond the scope of today's talk. It has its role, but we can see anti-VEGF has becoming the mainstay of treatment simply because it is by far a much superior treatment. It gives a better result, and it doesn't harm the retina in any way. But treatment is ongoing. That's the thing. Same thing PDT as well. Sometimes you need repeat PDT treatment. I hope I answered your question on PDT. It has its role, but it depends on the condition. There's watching TV or laptop. So one question is about watching screen time, watching TV and laptop affecting AMD. No, I don't think the blue light is really that much of a danger, honestly. Although you have all the electronic tools, you have an Apple product coming out, marketing all this night mode with taking out the blue light. Essentially, it's not a main issue. I don't quite believe that. All right. So what's more important is to get enough rest. Instead of lying in bed and watching with your screen for a prolonged period of time, getting enough rest is probably the more important aspect of it. But I don't quite believe the blue light is that harmful in a way. All right. Thanks for being with me this afternoon. Thank you for all the questions. Happy to answer them. And if you have any further query, you can leave me an email. I'll get back to you. Thank you very much.